Co-chairperson Dr. Santosh Mahapatra sir, convener Dr. Thomas Jayan sir, co-convener Dr. Samiksha as well, and I am Dr. Abhishek Anand who will be moderating the session. For the first step, I would like to invite Dr. Anusha Ajwani, who would be speaking on polychoroidal vasculopathy classification and non-ICGA classification diagnostic criteria. Welcome, doctor.
Good evening, everyone. I'm Dr. Anusha Ajwani, Vice Chairperson and Consultant at Ajwani Eye Hospital, Bhopal. Thank you for giving me the opportunity. And today I'll be speaking about polypoidal choroidal vasculopathy, its classification and non-ICGA diagnostic criteria. So PCV is a subtype of neovascular AMD characterized by nodular dilatations arising from the neovascular network that ramify mainly in the sub-RP space and which are best seen on ICGA. So coming to the basic characteristics of PCV, on fundus evaluation there is presence of orange-red lesions found at the posterior pole of retina. On fluorescein angiography there is dye leakage which occurs from the lesions, and on ICGA there is presence of distinct polypoidal lesions. Characteristics of active PCV include clinical, OCT or angiographic evidence of any one of the following, that is vision loss of more than 5 letters, subretinal fluid with or without intraretinal fluid, pigment epithelial detachment, fluorescence leakage and subretinal hemorrhage. So PCV roundtable meeting panel of experts in Singapore 2010 suggested an angiographic definition for the same, which states the presence of single or multiple focal nodular areas of hyperfluorescence arising from the choroidal circulation within the first 6 minutes after injection of ICG with or without an associated choroidal interconnecting vascular network. Presence of orange-red subretinal nodules with corresponding ICG hyperfluorescence is pathognomic of PCV. Coming to the pathogenesis, it is not clearly understood. However, there is propensity of choroidal vasculature for dilation and aneurysmal formation. Coming to the classification, the Japanese study group of PCV in 2005 suggested the classification of PCV, according to which in quiescent PCV there is presence of polyps in the absence of subretinal or intraretinal fluid or hemorrhage, exudative PCV in which there is exudation without hemorrhage, retinal thickening, PED, subretinal lipid exudation, and hemorrhagic PCV in which there is hemorrhage with or without other exudative characteristics. On the basis of size, with involvement of outer choroidal vessels, it results in larger lesions which are easily diagnosed on biomicroscopy, and involvement of middle choroidal vessels results in smaller lesions diagnosed on angiography. Based on number or arrangement, it can be solitary, arbitrarily defined as 1 or 2 polyps, or multiple, which can be arranged in the form of a ring or cluster. Based on location, it can be peripapillary, in which more than half of the lesion is located within 1500 microns of disc margin, macular, in which more than half of the lesion is within 6000 microns of center of foveal avascular zone, excluding the peripapillary zone, extramacular, in which more than half of the lesion is located outside the above two mentioned zones, and multi-location, in which the lesion straddles all over the 3 regions, with none of them containing more than half of the lesion, or if there is more than one contiguous lesion. Coming to the updated nomenclature, an updated consensus nomenclature and non-ICGA diagnostic criteria has been recommended by APOIS PCV work group in August 2020. So according to this, here an international panel proposed and validated a diagnostic set based on combination of OCT signs and color fundus photographs, which can differentiate PCV from typical neovascular AMD without relying on ICGA. The propositions included, the work group reviewed clinical and imaging observations related to the 2 key components recognized in PCV complex, often referred to as polyp and branching vascular network. With additional information gained from ICGA, OCT and histology, panel consensus is that PCV is a variant of type 1 neovascularization within the AMD spectrum. The terms polypoidal lesion and branching neovascular network are recommended rather than polyp and branching vascular network to describe the 2 lesion components within the PCV complex. Coming to the 9 non-ICGA features evaluated for predictive value of PCV diagnosis, of which 6 are based on cross-sectional OCT, 2 are based on color fundus photograph or fundus evaluation, and 1 is based on end-face OCT. So coming to the OCT features, there is presence of a sharp-peaked PED which is narrow-peaked PED with an inverted V configuration, also described as a thumb-like protrusion. There is a sharp vertical incline more than 70 degrees on at least one side. Sub-RP ring-like lesion in which a round structure is seen under the PED, and it may have hyporeflective center and hyperreflective outline. Complex or multilobular PED in which there is a notch in PED resembling an M. Double layer sign, thick choroid with dilated halar layer vessels. Presence of a fluid compartment which is predominantly SRF with or without mild IRF. End-face OCT features including complex RP elevation in which hyperreflective branching vascular network connecting multiple PEDs is seen. Now coming to the fundus features, there is presence of extensive subretinal hemorrhage and presence of one or more orange subretinal round elevations. A combination of 3 major criteria achieved an area under the curve of 0.90, and that is sharp-peaked PED on cross-sectional OCT, sub-RP ring-like structure on cross-sectional OCT, and complex RP elevation on end-face OCT. This set of criteria serves the need for most clinical situations, allowing for a quick, practical, and non-invasive method for differentiating PCV from typical neovascular AMD, especially in clinical settings that do not have access to ICGA. Thank you.
Comments from your side?
No, I am aware of this classification, Anusha. This has come in August issue of IGO also, I think. And that's a very illuminating because the relevance of this classification is further enhanced by because a lot of people may not have access to ICGA and hence the relevance, and because the concordance is pretty high, as you said, area under the curve for at least sharp peak PED, and there are major and minor criteria listed here.
The 3 major ones are that sharp peak PED and confluent ones.
So people should not rely that ICGA has to be mandatory there.
Yes, sir.
There are a lot of other things which have been said in this article.
Yes, sir, but I could not finish everything in this.
I think you should refer to that article, and people can read that article when.
Definitely, sir.
But suffice to say that it's important for clinicians to recognize this entity.
That's true.
Because it's frequently misdiagnosed as ARMD.
ARMD only,
by
yes.
a lot of people, and because the management may differ.
Definitely,
what I personally
sir.
feel is you see drug of choice is today aflibercept
Yes,
monotherapy,
sir.
and not bevacizumab or not ranibizumab, because
Yes,
the
sir.
results are not as great.
That's true.
So that has to be that also has been emphasized in this.
Yes, sir.
And brolucimab, which is a newer kid on the block, also may have a role in specifically in these entities, provided they are resistant to aflibercept.
Yes, sir.
Because PDT is no longer available.
Yes.
And therefore, all this average study, blended study, they have come to conclusion that aflibercept monotherapy is nearly as good as PDT or the combo therapy.
Yes, sir.
Thanks, Anusha.
Thank you so much, sir.
May I welcome now Dr. Manoj Saraswati, sir, to speak on multimodal approach in gaming.
Thanks AOS for giving me the opportunity to speak on this topic. This is a common topic, but we have done extensive work since last 25 years on this topic. I don't have any financial disclosures. As you know that diabetic macular edema, there are certain facts. It is a chronic, progressive and difficult to manage. The systemic factors plays more role than the local factors. That is ocular factors, more prevalent than any other diabetic complications of the eye, that is TRD and vitreous hemorrhage. There is always and loss of quality of the vision, and that too in a executive patients, which is a common cause of frustration. And being a refractory, it is causes the tension to the both the patient as well as the doctors. The basic pathology is not known, but it is known that it is a multifactorial and it is a progressive. It is in response to the raised intracellular sugar, hyperglycemia, which causes the release of free radicals, PKC, and AGE, which in turns causes the hypoxia, ischemia, that induces inflammation, releases VEGFs, and there is alteration in the vitreomacular interface. So in few studies it is found that it is a chronic inflammation and which causes the breakdown of the blood retinal barrier, capillary occlusions, and tissue ischemia. So all we know that diabetic macular edema is a multifactorial etiology. It is a multimodal imaging is required and multimodal therapy is also required. Previously we used to do the classify it into the clinical as well as angiographic classification like focal, diffuse, ischemic maculopathy as well as mixed and cystoid type of maculopathy. The DME management and its role of OCT has been changed the world of retina surgeons. Before OCT and after OCT, the management has been changed. We know that there are several types of presentations on clinical pictures we can get because of OCT, before treatment, after treatment, and response to the treatment, and why there is no response to the treatment. That is possible because of the OCT. So, what are the normal treatment modalities which we are using is lasers, anti-VEGFs, and steroids as well as the surgeries. The lasers are not suitable in all cases. We will see that, and most of the times the systemic factors plays a role. Patients hyperglycemia, patients hypercholesteremia, as well as the renal status and other systemic factors also plays role. So it won't respond well to the treatment. So when we come across with the diabetic maculopathy or diabetic macular edema, then what is in our hand is that we should treat with the anti-VEGFs, we should treat with the lasers, with the yellow micropulse lasers also available, Ozurdex, IVTH, as well as if it is associated with EP retinal membranes and reluctant, then we can consider surgery, or in altogether we may have to consider combinations of one after another, or if one is not working, then another. Then in such reluctant cases or long-standing cases, there are several questions are asked by the patients, frequently asked. Is the laser redundant nowadays in diabetic maculopathy? What is the end point of the anti-VEGF? Will laser add reduce anti-VEGF therapy? What is the ideal situation for steroids? How does one reduce surgical or treatment course? Then we know that this is the ischemic maculopathy which can be diagnosed with the angiography as well as the OCT angiography nowadays. That is one of the cause. Apart from that, if peripheral ischemia is there and if you have not treated properly the periphery in a PDR cases also, that can cause also the maculopathy. That is to be noted down in ultrawide field angiography. Another thing is the focal maculopathy, which we know that the succinate hemorrhages, succinate exudates are there around the microaneurysm. These can be treated well with the laser therapy is enough, and we know that the laser works here. But there are certain limitations to the laser. If it, the microaneurysms or leaks are in the papillomacular bundle, the lasers you cannot fire more and patient will lose the vision. So, and if it is a diffuse type of maculopathy, obviously the systemic factors plays a role and one has to take care of the hyperlipidemia as well as the renal components and sugar components, and then only it works. And in such situations, what is multimodal is that first you have to give the anti-VEGFs several times and then do the lasers, and again you have to keep on injecting the things till the systemic factors come under control. Another things are there. We know that the anti-VEGFs works very well. Within hours or within few days, you get the good results after anti-VEGFs. So whatever the anti-VEGFs you are using, it works if it has to work, because most of the diabetic macular edema is because of the RES VEGF component in the intraocular component, VEGF component. And you can see there are several pictures which are pre and post anti-VEGFs. But the, despite of all these, there are certain cases which do not respond properly or marginally they respond. In such cases, what to do? Still we have to keep on doing. There are certain cases here, I am seeing that he has received almost 16 ranibizumab, but it was not responding well. Then we have tried brolucizumab in this case off label, and after 3 injections you can see that it has come down to the normalcy. We don't know what is going to happen, and in these cases particularly it is very important that the patient keeps on coming to you years together. So it's your responsibility and treatment policy making which is suitable for him and advise that treatment modality. That is how it is a multimodal treatment according to the patients. If it is associated with PDR, then obviously the anti-VEGF is the first line of treatment. If it is associated with renal as well as hypertension, then obviously anti-VEGF first and then lasers. There are certain situations of maculopathy where the hard exudate crystals are subfoveal, then what to do? Still, as per DRCR net classification or the guidelines, we keep on treating, and you can see in the right side image, the patient has responded and hard exudate crystals have gone, and the vision also come back to little bit better than what it was started. There are certain cases where there is a mixed type of retinopathy where you have to keep on trying all the types of modalities, and one fine day you will get the results. Another modality is the steroids. Steroids, you know that they are pan anti-VEGF, as well as apart from the VEGF, it also acts against the various inflammatory modulators. And in those cases, we have to see for the biological indicators, or that is what is OCT markers, where the intraretinal high reflective things are there, then subretinal fluid is there. Obviously, the steroid is the first choice, and you can see that after steroids also you get the resolution of the edema. If these are the cases where it was a reluctant. If it is a post-operative or this is a pseudophakic cystoid macular edema in diabetic, obviously IVT or PST also can work. Here you can see that with the biomarker studies you can think of giving the steroids. And there are certain situations where the ERMs are there. ERMs are there with diabetic macular edema, then obviously surgery is the choice. You can see the pre-operative and post-operative pictures, and they work very well. And whatever the treatment, this is what I have observed, sir, in last 20 years or 22 years of the practice. Most of the time, because of multifactorial and multi-etiological things, you treat it, the edema goes again and again, rebound edema is the rule most of the times, and that is to be taken, and it should be considered and counseled very well with the patients. With the current modalities available, new molecules coming and their durability, you have to keep on treating. And but one thing is sure, that with the systemic control as well as the consistency in the treatment, whatever the modalities, whether it is a combination or one molecule you are giving regularly, it is helpful. Otherwise, it is non-preventable, or there is no complete cure. Only thing that you can early detect and treat it properly. Thank you very much.
Thank you. Thank you, Dr. Manoj.
Thank you, Manoj, for this entire talk. But judicious use, you know, how to start, which patient to start anti-VEGF, which patient to start steroid, if at all, and when to shift. So these are the key concerns.
These are key. And for that, I will say that we should not depend only on the OCT. Always we should remember that what classification we have learned in our PG days also. That also works. Focal maculopathy, ischemic maculopathy, diffuse maculopathy, mixed type of that. If you know that what is the ocular manifestations, as well as you just
no, what thing
segregate.
is that something to take back is, all of us I think agree that we start on anti-VEGF agents.
Yes, anti-VEGF is
okay.
the
And
first
out
line
of the
therapy.
anti-VEGF agents, by and large, aflibercept scores over the others.
Yes, aflibercept.
One point
Nowadays
is-
we
yeah,
know that,
one
and
point.
the number of injections also has been reduced because of the duration of action of
The
aflibercept.
second point is when to shift, if at all you have to shift.
Yes.
So do you consider shifting after 2, 3, 4, 6?
Yes, we have to shift, and we have noted that even shifting from one molecule to another also helps, and shifting from anti-VEGF to steroid also helps. Particularly, you have to judiciously, as you say, that you have to see that why he is not responding, because of systemic factors or local factors. If it is systemic factors are not under control, then obviously whatever you give, it will delay the response, or a marginally response will be there. In that cases, as you ask, 4 or 5 injection we can try, again reevaluate the case, again ask them that he is spending so much of money and not taking care of the systemic factors, then there is no point in continuing that molecule as well as the same treatment. In that situation, strictly warn the patient, because whole onus is going to come. You at the end of the treatment, he is going to come with I have taken 4 injections, 5 injections. He keeps on counting.
Thank you, sir.
Okay.
Thank you.
Thank you.
Thank you very much, sir. Thank you.
Thank you for a wonderful compilation of cases, sir. May I invite Dr. Manav Jyoti Marvan for his talk on individualizing and personalizing of intravitreal injections. Manajyoti sir, is your presentation ready? Sir has to go on with that.
Dr. Burman, can you put up his presentation? AV team.
Please change the presentation.
Is there an issue? I mean, if there an issue, I can start with my presentation. You can connect, na? In the meantime, you can connect. Okay. So, connect.
Yes, Burman, you can start.
Acha, the slides are not moving.
नहीं दिखाई दे रहा है कि नहीं? Are you able to?
छोटा हो गया है और मूव नहीं कर रहा है. You can't control the slide.
Okay, fine. So, good evening once again. So, I'm going to speak on individualizing and personalizing injections in the eye. So, I don't have anything, any financial disclosure to make. So, retinal diseases are a leading cause of vision loss, as you know. Among these, diabetic retinopathy and LMD are the most leading conditions. So, at this moment, the anti-VEGF are the most important armamentarium in our hand to treat all these conditions, and we have a group of anti-VEGFs with different pharmacokinetic and pharmacodynamic properties, and also they have
Timer, can you put on timer?
different indications also in different conditions. So along with this, we have some newer agents in the pipeline. We have steroids, intravitreal steroids, and multiple new delivery systems are also coming up. So with this, lots of economies also involved. These devices are, medicines are quite expensive, and with this, lots of resources are also involved. As a result, there are multiple multinational companies and patients are here in our both sides, and we are pitched among these companies and the patients. So there is a high scope of malpractice of these anti-VEGF medicines into today's day-to-day practice. So how to improve outcome with this anti-VEGF? So most important thing is the individualizing and personalizing treatment. So how to individualize? Clinical experience. So number one is a clinical experience with the clinician. Number two, innovative diagnostic modalities that are available in our hand and proper application of them, and also deep learning or artificial intelligence. So among the innovative diagnostic modalities, OCT and OCTA are the most popular intensity modalities nowadays after protein angiography. So Opta allows non-invasive high resolution imaging of retinal choroidal neovasculature. So this is an example of case of subchoroidal neovascularization. So you can see the subretinal hemorrhage, subartery hemorrhage, and there is a CNVM here at this point, and this is next is the post-treatment photograph. You can see the change in the pattern of the CNVM here. So imaging biomarkers, definitely they work it. They help in clinical diagnosis and confirmation. And often this does not correlate with BCVA, so we should not rely much on BCVA, which may be a misleading parameter. And they suggest a multitude of different disease origins. So then what is an ideal treatment regimen? So maximize and maintain visual acuity benefits. Decide when to treat next rather than whether to treat now. So we should have a proper roadmap in our mind how to treat, and titrate the treatment to match patient's needs. So considering all these factors, treat and extend versus this PRN. Treat and extend definitely has a upper hand on this on PRN, but in a scenario like India, so where we have a very high high patient load. It may be difficult to go for a treat and extend protocol, so most of the times we go for PRM protocol. So coming to the poor and non-responder, there may be suboptimal dosage. This is already at a very advanced stage, and there are multiple cellular mechanisms, lesion types, genetic variation, and potential tachyphylaxis. All these factors may contribute to poor and non-responder category. And poor access to clinics also may be one of the important cause in our scenario. So how to maximize the outcome? Re-evaluation of diagnosis, consider systemic factors, and if necessary, go for alternative therapies. So out of this, systemic factors is one of the most important condition in particular in diabetic retinopathy, because most of the times we discuss about anti-VEGF, how many injections we prefer, but we hardly will discuss about how much of blood sugar I prefer, how much of hemoglobin A1 or other systemic factors like creatinine or hemoglobin we consider. So systemic factors to be always to be considered in treating with anti-VEGF. So these are few of the examples of cases. This is a case of PCB. You can see ICG, you get small polyp at the baseline visit with subchoroidal hemorrhage. So after treatment with aflibercept, this polyp has hemorrhage is gone, but there is still PD is there. So multiple injections of aflibercept given, but still the polyp is there. So focal laser was done to the polyp, and this PD was resolved. So ultimately, the patient is while aflibercept is considered with the primary treatment of choice in PCB, but there is still a role of focal laser in these conditions. So coming to next case, this is another case of again ARMD. So you can see patient treated with ranibizumab. So after ranibizumab injections, 3 injections, you can see the PD is increased with SRF. So patient is treated with aflibercept, but there is hardly any response with aflibercept again. So we have gone to treat with the patient with there is most difficulty movement of the slide. So we had added PDT to the cases, and ultimately the patient recovered. This is the sequence of the OCT pictures of the same patient. So this is a case 3. It is an interesting case. Young diabetic patient in a third trimester with loss of exudates, retinal edema, and vitreous hemorrhage. Patient is diagnosed as PDR. So patient was treated with PRP and dexamethasone implant with strong systemic control. So after dexamethasone implant, after delivery, the patient's condition has improved a lot, but still there is a loss of exudates in the posterior fold. Then we switch over to aflibercept, and after 3 doses of aflibercept, there was cataract in the left eye, and lots of exudates have been resolved. So ultimately, this is the sequence of OCT pictures of the same patient, and ultimately, patient was happy with 6/18/6 vision in both the eyes. So the next big revolution in this personalization of anti-VEGF is deep learning and genetic analysis. So we're not going to discuss about all these things. So in summary, individual and personalized approach needs a thorough clinical knowledge, proper evaluation and follow-up of these patients, and there should be a good control of investigative tool and their correlation, and also patient compliance is one important factor in all these things. Thank you.
Dr. Barman, I think actually the topic was regarding individualized and personalized approach. And I think we need to differentiate between considering different aspects, but to specify when and which drug or which approach should be needed.
So there is lots of overlapping scenarios in this anti-VEGF. So which medicine will work well? So how to combine with anti-VEGF with steroid, how to combine with laser with anti-VEGF, when to combine, when to go for systemic control, that all these factors is to be considered. Okay. So my purpose is not to show that just patient has come, given one anti-VEGF, 2 anti-VEGF, 3 anti-VEGF, leave the patient like this.
That is what answer we were looking for, that how do you individualize and personalize? Because you see these examples you have shown are very, very good, and all of us have. So how do you individualize this treatment? How do you personalize? Suppose
there was multiple studies supporting different role of different anti-VEGF in different conditions. But the real world data is definitely somehow different, particularly in our scenario. So that is the most important. We'll have to see all the patients, we'll have to assess all the parameters of a patient, do thorough systemic evaluation of the patient, and patient's background, everything should be seen. So that is the problem. When the patient come to us, we just start with anti-VEGF or a steroid. So ultimately, after 2-3 injections, patient is not responding, we are referring the patient to that. So multiple factors are to be seen to get a proper response of anti-VEGF rather. So not that brolucizumab may be work in this condition, aflibercept will work in that condition, bevacizumab may work in that condition. They all have all overlapping mechanism of actions, but definitely they have some difference in pharmacokinetics and dynamics, and all these multiple studies have given lots of inputs in their mechanisms.
So thanks, Dr. Burman. Let's listen Abhishek about how do you adapt surgically to various macular pathologies.
On the outside, I would like to thank the All India Ophthalmic Scientific Committee for accommodating a very abstract topic of surgical adaptability in macular pathologies in a medical retina session. So thank you all for taking and considering my topic. So these are basically thoughts of various adaptability which you do while you're doing surgically handling any macular pathologies. And as a retina surgeon, macular pathology is one of the challenges which we encounter and that really thrill us. The slides are not moving. Okay. So the adaptability is the quality of being able to adjust to new conditions. So this is the system that we just had in our OT, and this is the OS4 system, and in this we come with the 3 LED illumination system. So you can basically play with the different wavelengths. And as you can see, it was just a blue wavelength which I had maximized, and once I switched to the yellow wavelength, the depth perception as well as the visibility of the ILM is great. And this is very, very handy when you are doing any surgery in which there is a myopic change underneath it. And this helps you to adapt and grasp the ILM, which is you have to going to handle it. So this gives me a very enhanced adaptability, enhanced visibility of the ILM. Now at this point of time, there is a macular hole, and here you notice that as I'm trying to grasp, the whole of the retina is moving. And this point, I have to adapt myself that I go and re-stain it again, rather than just continuing with it. And once I re-stain, you can see there is a very nice remnant or island of ILM which you can see. And this is going attack is basically what was pulling the whole of retina. So at that point of time, I was thinking that I'm even grasping the retina. And there is a red dot which sees that there is some amount of trauma that I might have caused during my previous maneuvers, which might be the exact lying middle in the papillomacular. This patient I closed it under gas, and this patient did very well. Now, ILM is one of the tools that we use to address different macular pathologies, and we use it in different forms. You can adapt, you can stuff it, you can put it over any defect, but then there are situations in which you don't have the ILM, so we'll have to learn and adapt ourselves to lost flaps or where ILM is not there. So this is another case. So this was a patient which was operated for macular hole RD, and when I was doing SOR, I could see that there is a persistent macular hole still. So I re-stained it, and then what I planned was an ILM translocation. So in this case, I took an ILM from other area and I translocated it, and fortunately this hole got closed. Now, you not always be that in cases which we will have you are amenable to ILM. So this is a patient which was operated in Maharashtra and came to Bihar after 2 years, and for that time it was carrying that RD. So this is an atrophic retina, and you can see there is a streak of break that has happened while I was sweeping the whole of posterior pole through my diamond duster scraper. So I used this break as one of the a template where I would take the retinal autograft, and in this case I did almost 270-degree retinectomy also, and I created it through a curved seizures, and then I moved this for using as a retinal autograft. Now the process here was not just the functional outcome, but I know that this is a one-eyed patient, and if this hole, unlike other holes, it might be do well, but in this hole, if I leave it well, then there would be certainly a retinal detachment which would be there. So this here was more of an anatomical outcome that I was looking for, and this is what why I do the retinal autograft in this case. Now, Another case is that in which you can do it in optic disc pit maculopathy. Here we have to, if you look at the fovea itself, there is a large hood. If I would shoot on OCT, and if I would just do any ILM peeling over it, then it would just blow out. So I do a temporal graft, and then obviously the literature, it doesn't say that you have to do an scleral patch autograft, but in my case, if I have to do, I would not just restrict myself to ILM, I am quite comfortable. Then I would also, I am also regularly doing a scleral patch autograph. And these are the result of few of the cases that I have done. Now, we all encounter long eyes, the patients which have MTMs, and then they pose a different. And there is a wonderful classification that has been given by Dr. Parolini and group, in which they have classified the tangential as well as the vertical forces and where it is balancing. And once you feel that the vertical forces are outweighing the tangential forces, there you have to go and negate that vertical forces. And here comes the role of macular buckling. This is a case which I did around 7 years back. This was a modern Devon T implant which we did. And this is the result post-operatively, in which we can, and this patient has not been treated for, this was just a primary modern Devon T implant. Although there is a shallow amount of cuff of SRF which was still present, but I think it was a pretty good outcome for it. And this is my mentor, Dr. Ihas. I wanted to show his video because when you are learning to adapt something, this is one of the, if you have various surgical macular pathologies, this is one of the great adaptations that I have learned. It's obviously very scary that you put a catheter just under the suprachoroidal space, and you transfer the whole suprachoroidal space, and then you inject a visco filler. And these are basically the skin fillers that you use, and you cause under the suprachoroidal space, you cause a sort of detachment, and that acts like a sort of a macular buckle. But then it is a temporary. And when I asked him that these spaces, they have their own memory, and they last for a really long time, although the fillers are, technically they should get washed at 3 to 6 months, but they have their own memories, and then you inject it. So this is one of the things that he adapted for his own convenience, and we can learn from it. But whatever you do, there will always be a unique problem, and this is a case in which they have a radial vertical, it's a horizontal slit, and the issue was that these slit had an outward folding of the retina, and I tried a lot of things to unfold it. One of the last resort was to do all around it and try to fill it. And finally, when I found it insufficient, I did a retinal autograft also, a large retinal autograft. I don't think this is a very great outcome, but then this is how you adapt yourself. Thank you. Thank you for my.
Great.
Yeah, wonderful, Abhishek. This is what was expected from you, that multiple videos and how you adapted to various modifications.
Thank you, sir.
The change of filter was very, very nice, where you shifted the filter and the illumination, and it became very nice visualization of ILM.
Even sir, Alcon is also coming with their different wavelengths. I think it's just in the process they are going to come with it. Yes.
And all the subsequent videos, I think there was a lesson to be learned. Do you have any comment to make? See, myopic fractional macular I am not a very strong proponent, because you have experience. You said you did a couple of years back.
Yeah, sir. So, but I just want to take a feedback from you, because you are a more avid practitioner and you have a long hand. I somehow feel that unlike the Western data, we don't get that much of MTMs in our practice. I don't know why.
We do get. These patients keep roaming
But
around.
the volume to build a consensus, that is what I'm saying, sir.
So in a third case where you shifted to a retinal autograft,
Yes, sir.
why didn't you try ILM graft?
So in that case, that was an atrophic retina, sir. I stained it, but the stains were not picking it up that well. And when I tried to pinch it to some sort of flap, it was just injuring the retina. Either the ILM had got fused or something, or the previous surgeon had already done it. It was an atrophic retina, sir. That is why.
Because
there is criteria that this dimension of the hole where you decide ILM versus
No,
retinal autograft.
sir, my criteria is fixed. If if I have to do, like, if what is the indication for doing a retinal autograft, I would first give a chance to all the conventional methods. In this case, I felt that I'm not able to, and if I leave that hole open, this patient is one-eyed, this might go. And sir, if I can share my thought process, sir, this patient after 1 month did a slight, there was slight SRF present at the posterior pole. I went again, and there was an anatomical integrity of the graft with the host tissue. That is what I could document on the video, sir.
No, Santosh, there are people I know of who without doing an ILM autograft, they straight away do retinal graft.
But in this case, that was something I felt that it was required, sir.
Anyways, thanks a lot, Abhishek, for these wonderful videos.
Thank you, sir.
We'll move on. Next is, I think,
Doctor.
Yes.
No, sir, stop, sir.
Comment on Abhishek because Ahab is a great friend and I'm doing life set on 19, but I think it's a great technique. The problem is that I think to visualize, he has a light cable with a red light, I think, the tip to see the tip.
Yes, sir. So,
the next we have is Dr.
I think we can do after sir has already.
Nati, you want to do first?
No, he can do. He's still
Yeah. Nati will sit for some time. So, we now have Dr. Himadri to tell us about tips in diabetic vitrectomy, another very complex disease, and I believe no two diabetic vitrectomies are the same. And the day I have a diabetic vitrectomy, I will either keep it at the last or we have the only case. Because they're so unpredictable, a simple looking case of diabetic vitrectomy may turn out. I'm talking of diabetic TRDs and not simple hemorrhages. But diabetic TRDs, especially if they are extensive TRDs, are quite unpredictable. Yes, Himadri, what do you have to tell us?
After this superheroic activities by sir, I will be presenting very basics.
Have you started? Or?
Is the video playing?
I hope you will be showing only videos.
Yeah, just videos, 5-minute videos. VLC है ना? Yeah. Okay, so we do injection, anti-VEGF injection first before going for a vitrectomy. So especially hardest are the patients with combined retinal detachment. So this one's one of fairly simple case. He had a cataract also. So we went for a cataract surgery along with the anti-VEGF injection in the first sitting. And we do injection 3 to 5 days prior to a surgery. So after 1 week, we went for a 4-port vitrectomy. So we always use a chandelier illumination because it helps to do a self-indentation. Most important is the posterior hyaloid in patients with PDR. So we have to make sure that we remove the entirety of the posterior hyaloid. Then we check the periphery and do a vitreous base shaving. And finally, a pan-retinal photocoagulation. And depending on whether there is a break or not, we decide to go for a oil or a gas injection. So patient did fairly well, one-eyed patient. Again, patients with fractional retinal detachments, we have to do a 360-degree vitreorexis all around initially. Again, it's not possible in every case, but in cases where there is a subhyaloid bleed, there tends to be some amount of gap between the posterior hyaloid and the retina. So in those cases, it's easier to delineate the plane. Again, we have to break down delamination and segmentation. So we try to remove the entirety of the proliferation, but first divide it into smaller parts, find out the plane, and then go for a complete removal. Finding the plane in between the retina is the most important thing. We can do with the smaller cutter these days, but sometimes we might have to take the use of a bent needle. So this provides a very simple way to delineate the plane. Once we are sure we have picked up the posterior hyaloid, then we can go ahead and do the rest of the case. Whenever there is an increase in hemorrhage, we go for a increased intraocular pressure, we increase the pressure, and we can also use cautery or even laser is helpful. Again, finally, we have to do a pan-retinal photocoagulation, and depending on the case to case, we go for an oil injection or a gas injection. So some of the things is we have to be ready for a taut ILM. So in those cases, whenever we find a taut ILM, we go for a ILM peel as well. So these are, in fact, ILM peeling also leads to reduced diabetic macular edema in post-op cases. Although I do not go for a ILM peel in every case. When I encounter a taut ILM, only then I do ILM peel. Otherwise, I leave it as such. Of course, there are schools of thought where in every case of PDR, ILM peel is recommended by some surgeons. Again, panretinal photocoagulation followed by a fluid air exchange. Most difficult ones are these combined detachments where it's extremely tough to delineate the plane. So triamcinolone acetonide is helpful, and whenever we find that there is some amount of PVD, we will try to create or increase it as much as possible in the regions where it is available, and the rest of the regions we have to go for a repeated attempts at lifting of the posterior hyaloid. Again, using a ILM peeling forceps at the disc, we can lift up the posterior hyaloid at the disc, and then we can go from center to periphery. These cases, we do end up with some iatrogenic breaks, and we have to make sure that we do a marking of the iatrogenic break using the cautery. And once that is done, we have to do a thorough laser in these patients. We can also use a bimanual approach in these patients, use a forceps to lift up the membrane, and then using the cutter to remove it and to do a delamination. Again, breaks sometimes do happen, and we just have to make sure that there is no fibrovascular proliferation at the disc, and go for a laser followed by oil injection. So with the better equipment and better technology at our hands now, all diabetic patients, we can hope to attain at least some amount of vision in most of the cases. Thank you.
Thank you, Himadri, for your wonderful videos. In fact, the key to all this diabetic vitrectomy is that you should release all the traction before you end up the case. Otherwise, you end up with the recurrence. So that's why the ILM peel, everything becomes important at that stage.
Nicely managed cases, Himadri, and as you properly described, take home message is be meticulous and try to give best.
The only thing I can add is in diabetics, don't pull too much. That's it. Because that results in formation of two B's, breaks and bleeding.
Yeah.
So that is detrimental. So don't pull too much with any kind of instrumentation. And I switch to bimanual very fast. Because that adds precision.
Right.
Precision means you can identify the bad from the good. So that is hallmark. Because it's very important to identify bad tissue from the good tissue. So let's hear the master now, how he does 3D. Master is here, so he will tell us how he does 3D. And is 3D better than what Himadri is doing?
Thank you, Lalit. So, again, slide nahi move raha hai. I don't know. Slide not moving around raha hai. I know, so ऑफ करना पड़ेगा. कुछ नहीं हो रहा है. In the meantime, Lalit can discuss and ऑफ करेगा.
So it's coming.
नहीं, that so
And
it's coming.
in between, do you prescribe anti-VEGFs to all the patients for this kind of diabetic retinopathy?
Yes, prior to surgery, I do anti-VEGF in almost all patients.
Sir, your take?
No, if it is a white-looking TRD, I may not, because it has to be an angry look of the blood vessels where I will. But I agree that it does help. It does help in majority of the patients. The incidence of per-operative bleeding as well as post-operative tends to get reduced. Sometimes if there is too much of ooze during surgery, I may end up injecting anti-VEGF at the conclusion of surgery also, in addition to that. So, because in all diabetics, whenever you do this extensive surgeries, There are a lot of membrane surgeries there. Whatever you leave on the table, next post-op day there is more ooze. So we are scared. So therefore, I tend to inject anti-VEGF at the end also sometimes, where oozing is more than what manipulation is being done. Combined RAG-RD and diabetic. TRD and RAG. Okay. So, so my answer to this is that if membrane surgery is too much, I generally do a two-stage, because or I have to choose my cataract surgeon who you can't just say koi bhi aa jaye. So I have to have a good cataract surgeon who will not give me a small pupil, who will not give me a descendant stria, because you see my life will become hell in case I keep operating. You see, so I have to choose my cataract surgeon. Within this specialty I choose. In case that person is available, I will do combined, otherwise I will not. Otherwise I will do a plain cataract surgery after 4 or 5 days, because diabetic TRDs are never an emergency. So therefore, when the cornea becomes clear, pupil is dilated, then I will do. If it's a small job, like only hemorrhage or a few attachments, then I may go for combined. But if it is extensive job, I will generally do a two-stage, or choose a cataract surgeon very wisely. That's important. Because you see, more than the pupil, what bothers me more is the stria. You see central small stria, I lose the depth of focus. I can't then add precision to what we are discussing. Any? Mm-hmm. Per-operatively. In a diabetic eye.
Diabetic vitrectomy is less.
Mm-hmm.
I think if you can see, as per your judgment, if you can see and do a good vitrectomy, go ahead for the vitrectomy first, rather than combining it.
Yeah.
Yeah.
If there is a little bit of posterior subcapsular component, then you might have to go for a cataract surgery. Only nuclear you can probably use.
Yeah, I agree with that. It's more of usually location. Only nuclear you will. But a small posterior polar will bother you. Recently I had this issue. A small, not very extensive, small posterior polar, we had to do a combined procedure. Absolutely. Yes, Nati.
Thank you, Lalit. So I'm taking on 3D vitrectomy for proliferative diabetic retinopathy, and as Lalit suggested, we'll go for the videos directly. So I'm using the Activa. I don't have any financial interest, and I think the advantages, there are a lot of advantages there, but this is what advantages to teach the entire operating team, your fellows, the nurse, the anesthetist, and I'm just showing you a pre-op diagnosis with the proliferative diabetic retinopathy with vitreous hemorrhage, actually in both eye. So you can see a 25 gauge vitrectomy being done, and after clearing the vitreous hemorrhage, you will see the fibrous tissue which has a traction. So I clear the tangential traction, clear all the, you can see it has been lasered well, and there was only a traction on the disc on the nasal side. You can see the sclerosed vessel. So this is a problem with the diabetic patient where they don't come follow up regularly, or they come late. So I think that's the reason you have to screen, diagnose and treat, and we saw medical treatment. All that will be there, but I remember Peter Hamilton said we'll do a wonderful laser and we can prevent proliferative diabetic retinopathy. It doesn't happen, and I think still we don't know what is the cause. Now AOS is doing a study. You can see all the traction released, and then we do a fluid air exchange and complete the fill-in pan-retinal photocoagulation. And this is around, there's a traction and with the break which we saw, which is in the nasal side fortunately, and finally you can see we injected the accentrix at the conclusion because we have removed all the traction. And this is the pre-op and post-op picture where you see the disc pale but vision is 618, pressure was maintained. So other is the PDR with a severe fibrovascular proliferation. You can see the severe proliferative diabetic retinopathy patient comes to you like this with a counting finger close to face. And I always tell them when you operate, you're touching the, like you're playing with fire, you can get burnt. So that's what I think I take informed consent. I spend a lot of time pre-operatively talking to them. I tell them nothing to talk, postoperatively. The reason is 1 out of 100 can develop neovascular glaucoma in case the things are not done well, and that's what I want the patient to know. And in case you do a wonderful clearing of the vitreous hemorrhage, the traction, and completely panretinal photocoagulation. So I am now covering temporally and going ahead, and now nasally. So we have to do extensive. Now after completing the laser, I am now releasing the traction on the disc, and you see he said 2B's breaks and the bleeding. So I think that's more important to clear. You can see in spite of all the things, there is a break happen. So you have to identify. So both has happened, bleeding and blood, and finally we did a endolaser photocoagulation around the break and then use the oil. This is the post-op picture, and then you also have a combined traction retinal detachment. You see here severe proliferation with the combined, and you will be seeing this is a totally like a disorganized retina because of the patient comes late. You will stain it with steroid, clear all the vitreous which is attached, or if there is no PVD, you make sure all are cleared, and then it's a combined detachment. You can see the configuration of the retinal detachment because there is a regmatogenous element, plus you have this severe proliferative diabetic proliferation which produces, and you are using the PFCL, and I'm actually doing, as he said, I'm doing a bimanual dissection under the oil, under the PFCL, so that the PFCL hand has a third hand, and there's a break in the periphery. So you're removing an en masse, the fibrous proliferation, and then identify the break, and then go do an endodrainage, then do a PFCL air exchange, and then air oil exchange. If you want, you can send this for any studies or a histopathology or histochemistry, but right now we can't do anything more active or even in proteomics. But you can see I did a diathermy around the break, and then did the endodrainage, and then also did a fluid air exchange, and completed the vitrectomy, reattached the retina, trying to remove the bleeding. But in this case, in spite of all the things, we couldn't remove most of the blood. But you have to actively follow the patient, complete endolaser photocoagulation, and all around we can see multiple breaks that happen because of the severe proliferation. You can see multiple ports have been used, and this was a fundus picture with the 636 vision. So many times these sort of patients, you can't remove the oil, you may have to wait for longer. And this is a very old video because I'm using a stiletto made by designed by Dr. Klaus Eckhart in '93, I think. I'm doing a bimanual dissection. The idea is you can see that we're using the forceps in one hand, and as he said, precision is the most important. I have about a minute. So this is what you clear all the vitreous membranes, and you can clear the entire thing. And there's one more surgery showing the similar. This was the picture, and the idea of the bimanual vitreous surgery is you can en masse remove it and avoid any iatrogenic break. So more and more you do similar cases, you can avoid breaks, and then you will be able to save more eyes. So favorable preoperative prognostic factor, shorter duration of macular detachment, limited extent, and all this we know. So absence of RD involving macula, absence of rubeosis, and all this patient, with all this I do surgery. So I think in the 3D you can see whatever we are doing, and this is what I am doing, everybody can see. One more advantage is in the layers, you can identify the two layers in the full screen, which we are doing the magnification. The finer details may be lost in the regular microscope, which we can see. But for that sake, the cost is too much to pay. But I did one wise thing. That's what Maipal said when he came, that I took a donation from Bajaj because he has diabetes and family, and they have given this, and per patient we pay the foundation. So surgery for PDR remains challenging, but has advanced due to improved surgical instrumentation and 3D vitrectomy. And recently did a very bad diabetic traction detachment with the 3D. I use RTO, but in Mexico I use the Alcon.
All the surgery you showed was
3D, but I didn't bring the thing. It's on the 2D. Thank you very much. Yeah, the last two are conventional because that is a 93 video. I just maintained it because now what I did is, instead of having a stiletto, I'm using two light cables, so you can have more light, and we can have a, not only for video, but at least for the visualization and clearing all the debris.
Thanks, Nati, for adding what Himadri also showed, but these are few additions to that diabetic armamentarium. And as I said, in diabetics, it is an unpredictable job sometimes. And you have to counsel these patients very,
Yes.
very well. So sometimes you see, therefore, never hurry up to operate a diabetic. Especially if the vision is pretty good, you may see, a lot of TRD. So my criteria of entering a TRD is vision. Is nothing else, because especially if it is one eye, you never know, this patient may have this good vision for 5-7 years, but if you intervene, maybe you spoil this vision immediately. So that has, I think, everybody has burnt fingers. So therefore, please be empathetic to the patient rather than showing surgical heroism for doing good videos.
Yeah, it's actually putting the hand in the fire.
Yeah.
Both can get burned, the patient and yourself, and sometimes they will fight with you or cry or go in depression. Or
But the reason I'm saying so is because I've seen a lot of young enthusiastic surgeon entering a diabetic eye with the 612 kind of vision,
Yeah,
and then you
not
face
advised.
5/60 vision for years. So that is what is, to me, not acceptable.
Yes, and in a yes. As in a situation where one eye is already lost and other eye is having some useful vision, and you are seeing a diabetic with a traction, it is you have to judge whether your surgery is going to improve the residual vision or not.
Thomas?
Yes, it takes almost 2 decades of practice to identify which all cases not to operate.
Exactly.
Therefore, I said, you see, till the time you have genuinely gray hairs, till that time it takes time to identify.
So
But that's why the last chapter of Steve Charles, and I have also written in my textbook, surgical self-education. You have to be sincere to yourself. How much surgery is your surgical self-education? That means whether your experience is good, in your own moral conscience, have you done the best to the patient? If you can't, why offer the surgery? They come and tell me, sir, your student is willing to operate. I said, see, he is willing to operate, but I am telling you, better not to operate, because this is like this. Still you go to him, talk to him, and then I am not going to discourage you. But if you have a problem, don't cry and don't fight with my fellow.
So the take-home message in one-eye diabetic is to be conservative.
No, not conservative.
Yeah,
You have to
but
discuss in
safe.
detail.
Yeah.
See, and the second is with
No, I'm not saying-
rubeosis.
No, Abhishek, I never said be conservative.
Correct.
You see, once you are inside, you should be reasonably aggressive.
Reasonably.
But what I'm saying is pre-op decision.
Correct.
You see, in a pre-op decision, in a reasonably good vision, I'm saying.
Reasonably.
Suppose the vision is, say, 6/18, 6/12, in the only eye, I will hold my hand.
Correct.
Yes.
You see, the only indication of going in a 6/6 eye is a GRT or a reg RD.
Right.
But otherwise, the TRDs tend to remain stable for a pretty long time.
Pretty long time, sir.
Yeah.
If they are laser, they
So
No,
I
the
think,
intervention you have to be careful, because with the rubeosis also I give anti-VEGF in the intracameral facing the bevel over the iris and then operate within for 24 hours. All that we do, but we make sure that we discuss the patient in detail with the referral doctor, with everybody, because they will say, that patient did well and why this patient is having problem. And if they develop a painful blind eye, that's the worst. Now fortunately with steroid, with all this anti-VEGF and lasers, I think endolaser also, the NVG I am not seeing at all. Otherwise, 35 years back we are seeing NVGs.
No,
And alcohol injection, Dr. Badrinath used to give.
For 5 days back, I saw bilateral NVG.
Oh God.
Operated diabetic.
Yeah.
So don't say that we don't see. We see.
No, I know, but mostly we are doing more lasers than before.
Yeah.
So I think that way.
So I think we had a wonderful session, and time also is up.
Sir,
and
can we ask for a
let me
quick-
thank
quick-
all the speakers who made this session wonderful, starting from Dr. Anusha, Manoj, Dr. Burman, Abhishek, Himadri, as well as our boss Nati, who made it very lively. So yes, Abhishek.
Can we have a quick photograph with all
Yeah,
the
yeah.
presenters, sir?
Thank you.
Good. Yes, sir. You